Yes, sir. We are live now.
Okay, fine. So, very good evening, Dr. All. I am Pankaj sir, working as a BDM MQ. Today, we would like to welcome all delegates, faculty for 3B series, a simply solution to learn the common gynecological problem. MQ has always been a forefront for the organizing the academic program. So, in continuation of such commitment, today we are here for this webinar, and I would like to call Dr. Dimpy for the further procedure of this webinar. Dr. Dimpy, over to you.
Hello, ma'am. Kamini ma'am is joining. Just
Okay.
half.
Yeah.
She's just opening the link here.
Okay, good.
You start.
You
You
can
start
start.
introducing us and then.
Sure. Okay. So, good evening and welcome, one and all. Today, we are gathered here for the fourth successful 3B series webinar, Learn Simply from Indore. Myself, Dr. Dimpy Modi Shah from Indore, feel immensely proud to welcome you all. And like we all know, the series is led by three passionate doctors, three passionate teachers, and international faculty who have always poured their blood, sweat, and energy in curating very knowledge and resourceful webinars for us. So today we are going to jump right into the webinar. To begin and to welcome, I request Dr. Archana Basir ma'am and Dr. Asha Bakshi ma'am to introduce Dr. Kavita Bapat ma'am. Dr. Archana Basir ma'am is MS DNB FRCOG FICOG consultant obstetrician and gynecologist director at Akash Hospital Indore, and she has been the chairperson for Foxy Imaging Science Committees 2015-2017. She has been organizing secretary ISAR 2016, managing committee member ISAR
Dimpy, you can cut our thing short. Just Vice President Foxy 2020 and that's it.
Dr. Asha
Same for
Bakshi
me
ma'am.
also.
Dr. Asha Bakshi ma'am. She is MS FICOG, lead consultant at Dr. Asha Bakshi Fertility Center, Motherhood Hospital Indore. Ma'am is Vice President 2022 West Zone Foxy. Ma'am needs no introduction. Ma'am, please welcome Dr. Kavita Bapat ma'am.
It's okay. बड़ी मैडम आ गई क्या देखो ना.
But she's coming. But let me just welcome all the our guests here on this platform. This is a 3B series started by us during the COVID time by Dr. Basir, Bapat and Bakshi, and it became very good platform for exchange of ideas and knowledge and very practical and in a simple way. And that's what we have been carrying forward. And today is our fourth session, which is dedicated to infertility. The program is being designed by Dr. Brajbala Tiwari. She has done the panel thing. And Dr. Kavita Bapat, I will introduce her in 2 lines only. She is past Vice President Foxy, very passionate doctor. She is approachable. She is a doctor with good vision and she has quality to bind with everybody. She just connects with everyone. So that's her quality and that's Kavita Bapat. So I present to you Kavita Bapat and Dr. Bakshi wants to say a few words about Dr.
Bakshi madam.
Few words about Kavita. Kavita is the she is the powerhouse of energy. And she is a very good surgeon, very good knowledge, and nowadays a very good speaker also that we have seen, and very good leadership quality. And today, I'm sure her dialogue with Madam Kamini Rao is going to be excellent. So we are very happy that we'll be listening to 2 big cases of our times.
Oh, sweet. Asha Didi, I think Madam has not joined, so that panel discussion should go on so that all the panel.
I think somebody, Dimpy, just said
somebody told me that she has joined. Dimpy?
Ma'am, I had a word with her directly. She told that she is joining. I think she has some technical error.
Just wait for 2 minutes, Dr. Kavita, because that's very important. Let's wait.
Meanwhile, we can formally introduce Kavita.
No. We formally introduce our panelists. By that time, you introduce the panelists so that the time.
Yeah.
It's our program. Yeah.
Okay.
So, Dr. Brajbala, by the time you introduce your panelist and panel moderator, and then once the Kamini madam joins, we introduce Dr. Kamini.
That's a good idea.
I will introduce Kamini madam. Am I right?
Will be
Yes.
on, but will interrupt their panel.
So shall I start with, so my co-moderator is Dr. Anupma, very good friend of mine, and she's from Uttarakhand, Rudrapur, and she's graduated of KGMC Lucknow 1987 batch, master's from NAMC New Delhi, fellowship in reproductive medicine from Singapore, owner and senior consultant at Fitula Hospital, Rudrapur, and primary member of State Surrogacy Board, Best Gynecologist in Uttarakhand award by Chief Minister in 2022, regular participation as faculty and expert in various national conferences, and she contributed chapter in Foxy publication, handbook in drugs in infertility, founder and present president Rudrapur OBGY Society. She is executive member of National Foxy Endometriosis Committee, executive member of Uttarakhand Society of OBGY, conducts regular hands-on workshops and conferences, and she is co-founder of NGO at Uttarakhand.
Dr. Alka.
So welcome you, Anupma, here for
Thank
this.
you, and thank you all the three big Bs of Indore. Thank you so much for inviting me.
And next panelist is Apurva Palam Reddy. She is MS OBGY DNB, fellowship in reproductive medicine. She is infertility training. She got infertility training at Brussels, Belgium, and diploma in gynae endoscopy, Kiel, Germany, diploma in USD training. I think Kamini ma'am had joined. Can we go first with dialogue, ma'am? Kavita ma'am?
Kamini Rao madam has joined.
Yes, madam is visible on. I
Screen.
think.
Yeah.
Yeah.
Yes.
Girish,
Good
I think
Good evening, madam.
Good evening, madam. Good evening, madam.
Good evening, Dr. Kamini. Good evening.
Good evening.
So, Dimple, can you
Yeah.
show CV of madam?
Good evening, ma'am.
I will introduce madam, Hannah. Am I right?
Yeah.
Yes.
Sorry,
Yes.
Dr. Bejbala, to interrupt with your this
No,
thing.
no.
You can carry on after the dialogues. Yeah. Let's listen to
Yeah, definitely.
dialogues about ART law, Dr. Kavita Bapat and Dr. Kamini Rao. Dr. Kavita, please introduce Dr.
Yeah.
Kamini.
Welcome.
CV.
I have. You just put a CV of madam. Yeah, thank you so much. Good evening, madam. Thank you so much. It's a simple 3V series, which we have started a long back, almost 2 years back. Myself, Dr. Archana Baser and Dr. Bakshi. And we're really happy that we do a small dialogues and small panel discussions and like everything. So welcome you today. Before like everything over there is, I just love to talk about our own Kamini Rao madam is. She's a Padma Shri. Dr. Kamini Rao is a remarkable individual and who has made invaluable contributions in the field of reproductive medicine. Her extensive list of achievements and accolades is a testament to her exceptional expertise and unwavering dedication. With an impressive array of qualification, including DGO, DORCP, MRCOG, DSEH, FRCOG, MOBG, FICOG, PGD, MLE, and FNAMS, Dr. Kamini Rao has demonstrated her commitment to advancing her knowledge and staying at the forefront field of her field. Her expertise recognized both nationally and internationally as evidenced by her numerous achievements. She has been committed to the education, dissemination of knowledge is commendable. The founder chairperson of Mediline Academics, a learning portal, and she has played a pivotal role in making the education more accessible to aspiring medical professionals. Her efforts has undoubtedly contributed to the growth of the development of medical community, and her role as a chairperson of the National Registry of ART Clinics and Banks of India. You have demonstrated a great leadership and organizational skill. And you, as being a Kamini Rao madam, being the instrumental in ensuring the highest standard and cares and the ethics of assisted reproductive technology practices across the country, and her contribution drafting into the guidelines of ART bill as a member of National Advisory Committee further highlight her commitment to the ethical and responsible advancements of the reproductive medicine. Your contribution in the field has not gone unnoticed, and evidence of the numerous prestigious awards you have received. The number one, which I always admire, that's a Padma Shri, very, very highest civilian award, recognized her the distinguished service in the field of reproductive medicine. Also being honored by the Lifetime Achievement Award by the ISAR and the FOXY. And these accolades reflect the profound impact she has made in the lives of countless individuals and the families struggling with infertility. You are also the editor-in-chief in the International Journal Infertility and Fetal Medicine, and you have been instrumental in the field of dissemination, cutting-edge research, and clinical practice. I have a lot to talk about you, but the most important thing when I make a list, who are my mentors, I always admire you through my heart. And I always being impressed by all the achievements, education, research, commitments, and the advancement which you have done is really, really important. Along with that, you have done many things for the community, and your contributions have improved the lives of many. So we'll have a small dialogue, madam. It's a dialogue about the ART law, because you were the instrumental in many more things. Brett, can you switch off your video so that the interview will be only this? And please stop the sharing over there. Thank you so much. So, madam, the questions are simple one, because you know the best, which you have done many things into you have done a contribution in ART law. So before starting, you can just put just opening remark regarding the ART law, and then we can have a discussion or a dialogue between each other.
Kavita, just let me tell you, you have given me more accolades than I deserve. And it's always kind of you to talk like that. It raises our spirits,
Yeah.
But you are no less. Okay, let me tell you. And we have seen each other's careers soar. And I've also seen you, the way you have been campaigning in the most dignified way. And that is what I like. Education first. And that is something that I value a lot. Now, coming to the ART guidelines and the ART technique, as well as the surrogacy, I think, it has gone through a lot of iterations. It started way back in 2000, and for which I was one of the committee members when there were not more than 4.
Yeah, I remember those.
And I would like to be proud and say that it started in Bangalore. However, as it went through, there were a lot of people who came and left, and we reached a point of 2021 when the parliament took over, and they sort of, in a very great hurry, made it a little bit more tweaked than usual. And as a result of which, there have been quite a lot of court hearings, purely because some sections of the public have not been addressed or have been marginalized. But if you looked at the 2010 and the 2015 guidelines, they are perfect to the extent of the law at that point of time or prevailing at that time. And the guidelines at that point of time also said that should the law change, that these guidelines will change with the law prevailing at that time. So which means that the act need not have to go through another change, because trying to change an act takes as much as 20 years. So keeping that in mind, that was the 2010 Act, the regulations, and the kind of changes that we had made. The other thing which was I was very much against, to have surrogacy and ART separate. Then there was another situation where I said that don't go for the surrogacy first, get the ART bill passed and then surrogacy, because there is no surrogacy without ART. But they went right up to getting the surrogacy passed till we had to, intervene at the Rajya Sabha and say, let's have the surrogacy board, only because they did want to stop surrogacy and the unethical procedures that were being followed. No doubt, I would like to clarify here that there were unethical things that were being done. And unfortunately, the papers also picked up these things and they highlighted it. So that actually showed red to the bull of the parliamentarians, who had been very conservative at that point of time. And so these things added more masala to what they were actually trying to do. Having said that, the surrogacy bill gained more teeth and went forward. But at the same time, they also decided that they can't have a surrogacy bill without the ART bill. And it came back again for hearing and put ART bill and surrogacy bill together. So that's basically the history of the two bills. And finally, to see the light of day, we had one in 2021, December, and then of course in January 2022. So we are now currently in this situation. However, you may say, what was Dr. Kamini Rao doing when all these things were being done? But you can understand that, doctors are considered to be the last preferential candidates to make laws, even though it is going to be, delivered through them. They feel that, they know the best. And so we will have to follow. So we were, responsible for the 2010 bill and not the current one. So if you were to see the 2010, that's good.
I'm just interrupting in between. I remember those days that when we and myself traveling with you a long, I think 8-9 years back from some, I don't remember the place, and you were so much busy into drafting and making the ART bill in a different, that you are just into it. You have worked so much regarding it. So I always remember whenever the ART bill, ART law is being spoken, I always remember that how much efforts you have given into it. But the most important point that this dialogue between you and me is very simple, madam. It is not for the infertility people only. Your and my dialogue on the YouTube will go for the all general Foxians. They at least also know a simple thing, because everybody is not practicing infertility, but most of them, they should know about the ART law and why it's so important. So our questions will be simply brief, madam. You already covered the opening by covering all the opening remarks by telling us what are the things, but in a simple manner, we'll make it a very crisp and very short one. That current legal framework of ART India, how does it implementation of the ART law, which I think you already talked about. So I
think, Kavita, the implementation of this law by, to the last T, it's going to be difficult. It's difficult because the need of the people, the unmet need of the people will not actually be met because of the way in which the laws have been faced. Now, if you say that the infertile population for a person who doesn't have a uterus or who has been hysterectomized for various reasons now needs surrogacy, now you can't have that, you must have altruistic surrogacy. I mean, that is namumkin. But the government says that it has to be altruistic. So who's going to give it? Relatives. Now, why do you think relatives will want to give altruistic surrogacy? I mean, these are something, again, which will lead to clandestine, below the table kind of exchanges, maybe in kind, may not be in cash, but nevertheless, some consideration will have to take place, because nobody is going to come and bear a child for somebody else without a consideration. So we are now, encouraging black marketing here, which we should not do, because the hapless couple are going to be penalized even more. Yes. So whatever they want to do, they're making it worse.
Yes. So you mean all the problems is more, these issues should be addressed more related to the surrogacies and intended parents, surrogate mothers and ART clinics, what you are talking about, and how to regulate.
Not only that. I think most of the people who are coming for self cycles would have anyway gone through self cycles. So I don't think there's any problem for that. But ones where you go for third party reproduction in terms of an egg or a sperm and making it altruistic, then I think that is being unrealistic. And the second thing is, of course, even for donor sperms and for donor eggs. Now, for example, if you want to go for surrogacy and the woman does not have her own eggs, now you can't go for surrogacy, because according to the law, the egg and the sperm has to be that of the couple, intending couple. Now, if the woman does not have eggs, then she can't go for surrogacy. Now, this puts a kind of a hold on their kind of right to reproduction. Right to reproduction has been a fundamental right given by a government or a constitution. And on one hand, you say there is freedom. On the other hand, you make it
You're
very limited.
restricting.
So
Restricting.
I think, one hand cannot contradict, or you must say that you can do the surrogacy, but whatever is required, for the loss of time or the amount of effort that there is, this is a kind of service. However much you may say that it is very patriotic, it is very service-minded. Even the service-minded thing, why only doctors,
Yeah.
patients, surrogates have to do all these things? Why not lawyers? Why not politicians? Why not parliamentarians do that?
Yes.
So I think this cannot be one rule for one and another rule for somebody else.
So in nutshell, that our representation in a government is not up to the mark. What I'm saying,
No.
we should be more into the governance. We should be more into the ministry. We should be more into the lawmaking. We should be more into the policy making rather than only practicing. A person like you should be there, man. What I feel, then yes.
No, I think, see, it's a double-edged sword.
Yeah.
One, we are meant to practice medicine.
Yes.
We are not meant to stand on the streets with a loudspeaker and keep doing talking. Second, in a mob situation, we are not black belt, wrestlers or something like that to fight a mob. We
Yes.
are doctors and so you will have to understand that a doctor has to do their job, conscientiously. Now, if you want to become a politician, you need a different frame of mind.
Yes.
But if, like in the West, if you have a select committee, okay, that looks into specialized laws and have the experts for that, like in the Royal College, they have the HIFA. So that doesn't come out straight away from the parliamentarians. They have a specialist group, committee, subcommittee, and they build it up and then give it to the parliamentarians. The
Yes.
parliamentarians look at it and then pass it.
Yeah.
So you don't have
Good
to get
advisory.
into the parliament to do all
Yeah.
this.
Yes.
Parliament needs to come to us as a subcommittee and we should give it to them.
Yeah, I agree with you. I think our dialogue will change in some other direction. Before that, I'll ask that how does this ART law is used into the PGD and the ethical consideration, madam? For the general OBGYN, they should know that how this law is regulating this PGD as well as the ethical consideration about it.
See, earlier we had said that maternal age can be used for this. As the maternal age goes beyond 38, 40, the chances of aneuploidy in the egg and embryo increases. So if you look at an embryo that is really looking good, it may not be a good embryo, need not be a normal embryo. So
Yes.
the only way you can find out is by doing a PGT or PGTA, that is aneuploidy. But if you are not getting that aneuploidy and you say, okay, I'll just put it in, that woman may have an early miscarriage, or she may not get pregnant, or she may land up with a Downs baby.
Yes.
Now, rather than she go through all that kind of psychological thing, it is nice that if she's old, she can be offered PGTA. But according to the law, maternal age does not form an indication.
Yes.
Only if this woman has had a Down syndrome or has had some genetic defects, then only PGD is allowed. So which means it curtails the use of PGD in women, and it has specific conditions on which you can do.
Yes.
That also is very restrictive in its practice.
Yeah, and the same with I think you like to talk about the you like to address the issues related to, again, the donor gametes, the embryo. Everybody's talking, no, the 7 and all that numbers are there. What are the implications and the donors and the recipient? For the general OBGYN, they should know the basic, who can give the,
Well,
who can donate the eggs, who will be the egg donor, like simple things.
See, when they talk about, once in a lifetime she can donate eggs, how do you monitor it? Unfortunately, if you talk about a kidney, you know that there's a big scar on the abdomen, so they can't keep on donating kidneys.
Yes.
Luckily, there are only 2 kidneys, and then they can donate one, and you have a scar, so you can say, yes, the kidney is donated. But here with eggs, it's like blood donation.
Yes.
Okay, you can keep on picking up the eggs. Now, suppose she goes there, they say that National Registry will have Aadhaar card, and then she can go there and once she can donate. But what is very unfair is that they put the onus on the doctor.
Yes.
that you must make sure that she's only donated once. Now, how does a doctor make sure that she's donated once? This becomes forensic medicine for us. Now, in a large practice, I don't know whether she has donated once or twice. So you have to now go to the registry and find out. But suppose she changes her Aadhaar card and her face, then you have to have fingerprints, then you've got to have signature, and then, of course, face recognition. So we are going to spend more time in having more secretaries looking at this. And finally, this lady, wherever she goes, her face must be flashing. Now, sometimes you may get all this, and sometimes somebody slips through the net, in which case the onus of responsibility is on the doctor.
Yes.
It's not on the bank,
Yes.
it's on the doctor.
Yes.
So which means that you're going to get penalized if that woman has come second time to you.
Yes.
So who would like to do a third party reproduction when all the blame is going to come on you? So I think you need to be careful that when you take a third party reproduction, you have to be fully sure that this woman has donated once.
Yeah.
What about the semen? It's the same story. How can you be sure?
Yes.
And the third thing is there is no confidentiality when you donate semen. There's only question of identity is revealed, but confidentiality is there, which means to say that if required, the name may not be said, but they will have an Aadhaar card. So the Aadhaar card is given. So when they take the Aadhaar card from the semen bank, the name number will be given. So we will have the name and number. So should there be any genetic abnormality, they'll be able to trace the person. Now, which person would like to come and give a semen sample if they're going to be traced? And then suddenly a 16 or 17-year-old girl or boy comes and stands in front of your house and say, "Hi, Papa," or "Hi, Mama, I am your child." It's going to be very, very embarrassing.
Okay.
So the man may not even have told the new partner that he has donated semen so many years ago. And
Okay.
suddenly he finds a grown-up child in front of him. Could be very embarrassing.
Okay.
So people had earlier, given samples because of anonymity.
Okay.
But now that anonymity has been taken out. The same anonymity even for egg donors has been taken out. So the number of people coming to donate egg or to donate semen is dwindling. So rather than increasing the number, one is altruistic, the second is identity. So on both counts, it is counterproductive. So both these things are going to be negative.
Yes, yes, yes. So basically, ma'am, we have a time slot given to us, almost 15 to 20 minutes. And I think about the impressive knowledge and the way you can put many things in a different way, we can go for the lights. And the last question, which I like to just put it in a way or a concluding way, so, once the law is passed, we have to follow. That's, I think you will agree, I will agree, and everyone agree. If we have to drive a car on the left side of the road, we have to. Now what are our roles as a ART clinics to be implementing the ART law and our responsibilities and obligations both. So yeah, those two things are very, very important when we talk over, and then we can conclude our dialogue over here, madam. The role of ART clinics, implementing the ART law, our responsibilities and obligations.
Yes, of course, Kavita. Once there is a law, there's no question of my gut feeling. I feel this, I feel that. You will have to put your gut out, or you have to be gutless or spineless, and cool your heels in the jail if you get caught. So the best thing would be, like a good citizen of the country, follow the law, or stop practicing infertility, and then you just do OBG practice. I think that also is very good. And let the infertility practitioners do their practice. I know there's going to be a lot of extra work, documentation, etc., but that is only to safeguard you. Make sure that the documentation perfect, make sure the licenses are perfect, and make sure that you protect yourself. It's better the patient cries rather than you cry afterwards, because you need to keep everything perfect, because this is one more draconian law, which is like your PCPNDT law.
Yes.
And this is one major way of making money as a racket by the babus. So I leave it to you, your
Yeah.
imagination, your boldness, your ethics will depend on that.
Yes, yes, yes. So in a conclusion, madam, so nice of you to hear all about the feelings, the way it should be, and the way it has been. So you have put it in a very nice manner, the way it is, and I always impressed by you all the contributions which you have done and the way you have done the dialogue with me. But the ART law is going to stay, and we have to follow it. That's my work message to each and every infertility specialist or a simple Foxian. Just read it properly, go through it and do it. Thank you so much for joining today, madam.
Thank you.
And
Thank you
thank you
so
so
much.
much. I think others will like to give their opinion also, and without wasting time, it's over to you. Thank you so much, madam.
Thank you.
Thank you,
Thank
Dr.
you.
Kamini, for
Thank
joining
you very much,
joining
madam.
us today. And it was really very nice to really have a simply being, understanding of ART. So now I'll pass it on to Dr. Bakshi to say a few words, and maybe we can do condolence for Dr. Sudesh Kamath as well.
Madam, you are simply superb. And the way you simplified the things, simplified the few points in the ART law was really great. And this is a thing that we can hear for hours together, and still we get new points out of it. But thank you so much for joining, and we really feel blessed. Thank you so much.
Thank you.
One thing I would like to express today we are really very sad by demise of our favorite embryologist, I think, who has performed maximum 60 procedures in the world, and that is Dr. Sudesh Kamath. He was a close friend to me, and in fact, he was the one to have first ICSI baby in Madhya Pradesh, and we were fortunate to have him. And I think he has given knowledge and has been instrumental in doing such good work. So, and this sad demise has really left us in shock. And I would like to pray for him, and may his soul rest in peace. So I wanted to give some condolence message for him.
Indeed, the sun in embryology did not rise today, and we all express our deepest gratitude and condolences to Sudesh Kamath sir. May he rest in peace. Moving forward with heavy hearts, we will shift to the panel discussion. A very interesting panel discussion by Dr. Anupama Futela ma'am and Dr. Brajbala Tiwari ma'am on optimizing the IUI results for all general obstetrics and gynecologists who are aiming to start IUI or who are already doing IUI. Over to you, Brajbala ma'am.
Thank you, Dimpy, and thank you, Kavita Bapat madam, Bakshi madam, and Base ma'am for making me part of this important webinar. And it was great to hear Dr. Kamina Rao madam on this ART Act. So moving towards our panel discussion, and I'm having with me my co-moderator, Dr. Anupama. She's very enthusiastic academician from Uttarakhand, Rudrapur, and we are having expert with us, Dr. Meenu Vaish madam. She's the pioneer in Uttarakhand, and she's very helping. And can I have CV of madam? Dimpy?
I'm actually
Could not read
yeah,
Meenu Vaish
yes.
for the
Okay.
CV.
So madam doesn't need any introduction. She is well known and very favorite of all of us. So welcome, ma'am. So our next panelist is Dr. Apurva, and she is young, enthusiastic academician, and she is very much into ART practice, and she is editor, decision making in infertility, director, International Fertility Academy, consultant, reproductive medicine and cosmetic gynecology, and she is from Bangalore, and right now she is secretary of Bangalore OBGYN Society. Our next panelist is Dr. Ekika Singh, and she is from Mau, UP, and she is having diploma in reproductive medicine from London, and she had been awarded many times by UP government and so many awards by Foxy. And welcome you, Ekika, over this webinar. Can I have next CV? Dr. Meenakshi Ahuja, and she's a very good friend of mine. She's Senior Director OBGYN Fortis, New Delhi, and she is President Indian Menopause Society Delhi, and she is Academic Secretary Delhi Gynae Forum, Vice President South Delhi IMA. She is past President Delhi Gynae Forum, and she was speaker at POXI and public forums, passionate about women's health and disease prevention. She is Secretary AOGD Breast Cancer Cervical Cancer Awareness Committee. I welcome you, Dr. Meenakshi, over here. Can
Thank
we
you,
have
Dr.
Dr. Seema? She is also a very good friend of ours, and she is President Azamgarh OBGY Society, National Executive Committee member, ISAR 2018-2022, ISPAR 21-23. She is co-author A to Z of PCOS, Everything You Wanted to Know. She is co-editor ART Fertility Enhancing Surgeries, The Synergy, Ovulation Induction Simplified, and she is very much having keen interest in infertility, reproductive endocrinology, PCOS, adolescent health, and she is spreading awareness about PCOS and adolescent health. So I welcome you, Seema Begu Pandey, for this webinar.
Thank you.
Dr. Anju Singh and couldn't join because of some mishap happened in family, and Dr. Rajul madam is busy in emergency. So we are going to start with our panel. So basically, the history, if we go to history of IUI, it took place in canines in 1784, and first human intravaginal insemination was reported by John Hunter in 1770s in Hypospadias male, and in mid-18 Sims reported on 55 intravaginal insemination with one pregnancy, because he believed that ovulation occurs during menstruation. And Dr. Shriman in 1953 watched human semen, and he reported first pregnancy with frozen sperm, but he couldn't announce due to so many issues that time. So for today's webinar, is there a place for IUI in modern ART? Why I'm bringing this point, because the argument was brought by National Institute of Health and Care Excellence, NICE, in UK, who published guidelines in 2013, stating that after 2 years of unexplained infertility, IVF should be offered with the complete exclusion of IUI. The public funding authorities gleefully jumped on and they refused funding for IUI. This was the story, but it is the tribute to the integrity of practitioners in the UK that the majority completely ignored these guidelines, and we are doing IUI and we are getting results, and that is the most cost-effective approach. So current is that we are doing IUI. So my first question with all the panelists, anyone can answer that what is the age, the most important factor for deciding the IUI is the age. Anyone can take this question?
Should I answer?
Yeah, go ahead, please.
So I think, like you said very clearly, that IUI is the stopgap between natural trying and for IVF. So definitely we know that the end is that if she doesn't conceive with IUI, it has to be IVF. So personally, I feel that although their guidelines would say 35, 40, I think, look at the AMH also. If the woman has time in her hands to conceive, and you can give her that much time when she comes to you with infertility, offer her IUI. If her AMH is very low, or you feel you don't have time, then I guess you have to kind of counsel her straight for IVF. You have to understand that when a patient comes to you for infertility and she wants to conceive with her own eggs, do not continue trying IUI till the time you reach a point where when she tries for IVF, there are no eggs left. So despite me not doing IVFs in my practice, that's the first rule you have to take, that if the AMH is low, think about IVF faster. But if a woman is less than 40, preferably, of course, less than 35, IUI, it can be offered to her if she's keen to.
So very beautifully answered, Dr. Meenakshi, that age is to to be considered, but it is just a number. So we have to consider so many things whenever we are taking decision for IUI. So these are the different figures by this study that with increasing age, the success rate is decreased. But even in the younger population, if there is many factors like mild male factor, endometriosis, PCOS, so we have to shift to other procedures. So, so this is very beautiful article on IUI review and systematic assessment of the evidence that supports global recommendation. So what shall be the factor for patient selection for IUI? My next question to any Apurva or Bebu can take.
Dr. Seema can take it.
Yeah, Seema. Anupama, can you go ahead with the next questions, please?
Thank you, Brijbala. And
Something I could make.
Just a second. After that very interesting session of chat between Dr. Kamini Rao and Dr. Bapat, we are ready to set the ball for this very practical session, that is IUI optimizing the results, because that is a procedure which all the gynecologists are adopted to take it easily. And I think we should take a pause and keep looking at the latest reviews, and sometimes it might help us revise our practices. And this was a very recent article, as recent as 2010, I think. And the further slides which are there, many of them have been taken from this article, whatever the recent guidelines are. And I would request my very dear friend, Dr. Seema. I would, at this juncture, I would acknowledge Dr. Seema Pandey, popularly known as Bebu. She's a very good friend of mine, my school friend, I should say. And she's the one who has led me to this path of infertility. And it was, if she would not have been here, I would not have probably had an IVF center or practicing infertility. She gently trained me and brought me in this field. And I'm very thankful to you, Seema. And it's my good luck that I have to ask this question to you. And I wanted your inputs, that what patients would you select for IUI? What would be in your mind, and in which patients you would not go about it?
Okay. Thank you, Anu. And I'm lucky to have you as a friend in my life. Love you loads. क्योंकि ये वीडियो में हम दिखते क्यों नहीं है, हमारे को फोटो क्यों नहीं दिखाई पड़ रही है? Video is not on. So patient criteria when you are going to do IUI, first of all, we have to see, as you are saying, that what are the criteria, who are the patients where I will not be doing IUI. So what I can say, absolute contraindication is only bilateral tubal block. Otherwise, anyone who is having unilateral, at least one tube patent, who is making eggs, whose endometrium lining is growing in synchrony with their oocytes, all those people can go for intrauterine insemination. Especially if I talk who are my favorite people, I do IUI. So unexplained infertility comes on top, where I have been seeing that this lady is making her eggs perfectly. There is ovulation, everything is fine in male as well. All the visible things are normal, but she's not conceiving. So unexplained infertility is first indication where I will go for IUI. Mild male factor, endometriosis, stage 1, 2. So up to 3, if tubo-ovarian relationship has been restored post-surgery and couple is young, I can go. People where I will suggest otherwise are couples who are more than 36, 37 years of age. I will advise not to go for IUI, looking at the success of the IUI in these people having Only anovulation as a factor I am not going to do, or severe male factor or motility disorder especially. These are the patients where I will not advise. So for me, unexplained infertility, sometimes PCOS, who are ovulatory PCOS, everything is fine and they are not conceiving. IUI per se is not an indication, but I take them for 1 or 2 cycles of IUI to just save the cost and make that patient comfortable. And that has been accepted by guideline 18 as well.
The ovulatory dysfunction, these mild ovulatory dysfunctions are also corrected when you, along with IUI, you are giving some sort of extra support in the form of ovulation induction. So that would add to your results. Thank you so much for that wonderful answer, Seema. And as we know that, a favorite patient for IUI would be, ideal patient, as Seema just said, would be a patient who's, say, around less than 35, definitely should be less than 40, at least one patent working tube. She should be having easy access to uterine cavity, and the post-wash counts should be at least 5 million. So that is the criteria of selection. And the age duration is, a little controversial. I just looked at some evidence, and some people say that less than 6 years, they are happy, and more than 6 years, they would not waste time with IUI. But there are evidences which say that even in patients who are more than 3 years, they would not waste time. And there are also some papers who would say that duration is not so important. So overall, whatever latest research I could find and evidence was there. So this is what I found, that 6 years should be probably the criteria in which we should say that more or less chances of success are there. Less than 6 years, better chances. Less than 40 years, better chances. Etiology, as Seema explained, these are the ones who are better ones. And sperm count, definitely this more than 10. Motility more
Anu, I will differ regarding the duration. According to me, duration is one of the most important factor, irrespective of the age.
So the duration, there is a controversy. This is what, can you see 2 studies that I have shown? In this study, they are saying less than 6 years or equal to 6 years. And this second study, this one says 2 or 3 years. Okay. So
I think I'll have to agree with Seema ma'am, because I think this is a very old study. This is a 1919 study. There is another consensus which says 4 years of duration is what is considered as an effective space. And again,
2004 study that which I'm showing, and these are saying
the
less
down
than
study,
3 years.
yes. So which is what I'm saying, ma'am, that there is a 2010 or 2012 study which says, again, I think we are taking studies too seriously. We need to understand that all of this is a European population where their AMH levels and their health status and everything else is much different. So if we simply cannot give a message saying that up to 6 years of marriage, trying and 40 years.
Of course, we have to see the patient in total.
Yes. In our country, infertility is not only about numbers. We have to look into so many other factors as well. And all those factors together work as a treatment of choice. Same with infertility. So we should not restrict ourselves according to the numbers.
Very good. So coming to the next thing, anybody can take this question. If a woman is already ovulating, why do we need to do extra stimulation in a woman where we are planning for IUI? Maybe Apurva, you can take this question.
Yes, ma'am. Ma'am, just like there is something which we call as, performance pressure for men, that, they're not able to kind of actually ejaculate on the days when we tell them to kind of fertilize. We have seen so many times, women who actually have regular cycles and, have normal periods and everything else. they fail to ovulate on 14th day when especially they're planning for pregnancy because of the stress aspect of it. And I keep telling my patients that, you know, people who are trying to get pregnant have less chances of getting pregnant than people who are not trying to get pregnant because they're so focused on the dates and everything else. So I think especially when we're looking at the only time that I would kind of consider a natural cycle IUI is, let's say a patient has come to me from abroad, UAE or something like that, and she's already on the day 9 of her cycle. I can already see a 16 or a 17 follicle which is there, great lining, and she probably will travel back in another week or 10 days. I think that's the only circumstance where I would kind of consider doing a natural cycle, but otherwise it's stimulated all the way.
So that is what we say, that when we plan it, then we have to add something. Dr. Meenu, as an expert, would you want to add something to it?
Yes, definitely, Anupama. And I'm listening to this panel discussion. First of all, the talk of Dr. Kamini Rao was very interesting and very useful. And this question, we have to take the overall factors. And since the patient is already trying to conceive and she's not able to conceive, so we need to give ovulatory drugs. We need to ovulate so that we can get at least 2 to 3 follicles. We can get 2 to 3 follicles. So it's always good to get, in that way we can get a better result.
Thank you so much.
So basically there are many studies which are showing that whenever we are doing stimulation as compared to natural cycle, the success rate is more with IUI.
When the number of follicles are more, then the results are better. Yes. So we have started stimulating a patient, and more than 2-3 follicles have developed. But along with that, there is also a simultaneous increased risk of OHSS. So in what patients would you, Dr. Meenakshi, cancel your trigger? You are stimulating a patient, but then you decide that, no, I will not move forward.
So at least I would cancel the trigger if, when the day I'm planning to give the trigger, she has more than 2 dominant follicles, which are over 15 millimeters in size, or more than 5 follicles, which are more than 10 millimeters in size, irrespective of whatever the E2 levels may be. If the E2 levels are more than 1500, I would definitely cancel and probably delay using something if the lining is not good enough.
Thank you so much. Thank you so much. Wonderful, Dr. Meenakshi. So when I was looking at the literature, there was one interesting thing that I found, that occasionally people have tried aspirating excess follicles at the day of trigger. I found it funny actually that they are aspirating two of them and then moving forward with the trigger. So next I would ask Dr. Ekika, and later on I would want all our panelists to give their opinion that how would you go about with the stimulating your patients, your takes on natural cycle versus oral drugs versus gonadotrophins. So Dr. Ekika, can we start with you, please?
Hi, good evening, everyone. Well, when it is to IUI, probably I would not go for a natural cycle IUI. It has to be ovulation induction. Probably that will help to streamline the whole cycle and to get me good 2 follicles, at least 2 follicles. And as in the previous question, it was very well answered by Dr. Meenakshi. I would see if I have at least 3 follicles, still my cutoff is 3. Even if 3 are okay, then I might do IUI. So probably oral ovulation is the first thing which I'll go with. And yes, in cases of a severe PCOS, and if I plan to take her for IUI and she is not responding well to ovulations, then I might add gonadotrophin, and aim is to get at least 1 or 2 follicles. So this is how I would proceed. And then obviously seeing on the day 14, 15 or whichever day, a dominant good follicle, a good color flow, Doppler flow, so that I can trigger her if I'm planning her for a proper IUI and then doing IUI.
Thank you, Ekika. Thank you so much. Seema, would you add something here?
And Anu, I couldn't hear the question. Can you repeat it?
Is there any input you want to give while stimulating a patient for IUI?
So what is my protocol for IUI? Do you want to know?
Yes, yes.
Yes. So, as per our knowledge, we all know that the best results of IUI cycles are with pure gonadotropin cycles. Yeah, but I am bit conservative when it comes to IUI because the success rate of an IUI cycle is overall 5 to 8% per cycle. I do not want to go full gonadotropin cycle. I try to save some money and number of pricks to my patients. So I give them mixed protocol of oral Ovolugen along with gonadotropins and pure oral Ovolugen cycle I avoid doing. Very rarely some ovulatory PCOS with letrozole. If she has already made 2 follicles and I have planned IUI afterwards, that's okay. You can do it. You can
Thank you so
do
much. So that is
IUI
what-
with oral Ovolugens in unexplained infertility patient. That is first line treatment. But the best result for IUI is with gonadotropins only cycles. And I do use gonadotropin plus oral Ovolugen. And my Ovolugen of choice is letrozole most of the time. Clomiphene, I
Thank you,
avoid.
Seema. Thank you. So that is what the latest evidence says. This is a very recent guideline, and they say that the letrozole co-treatment, even in older patients, their conclusion was that if you are giving only gonadotropins, then the hormonal profile was not as good as when you are initially giving a letrozole and then later on adding gonadotropins. So in those patients in which we believe that only gonadotropins is the option, sometimes even the cost is also helpful, and the day 7 LH levels as well as progesterone level at the trigger day was more friendly when we were giving letrozole and later on gonadotropins. As
reason being that letrozole being aromatase inhibitor, it is by increasing the androgen, it is making your follicles more sensitive towards your FSH. So your total required dose of gonadotropins is also decreased. And letrozole is not affecting the endometrial lining at the same time. And LBR is better not only in PCOS, even in non-PCOS population. A long-ending debate between Ligro and other people who doesn't believe that letrozole is meant for IUI in unexplained infertility patients.
Thank you, Seema.
Just want to ask one thing. Anupma, here I want to ask, the day of gonadotropin adding, on what day you are adding? Seema, what day you are adding gonadotropins?
Basically, when you are giving letrozole, you can, if you are going to give it for the first cycle, you have to look at your aim. If in last cycle she has not responded to your letrozole 5 milligram dose, this time your aim is to rise the threshold. If you want to cross that threshold, your letrozole and gonadotropin should be started on the same day. And if you just want to extend the window, FSH window, then you start your gonadotropin the day you end your letrozole. From next day onwards, till your follicle reaches the size spot trigger. Every day, the dictum is you cannot use 3 doses, you cannot give alternate doses. Alternate day, you have to give every day till the follicle reaches the size spot trigger. So if I want to, if my patient has not responded in the previous cycle, I'll start it together and give 3 injections and then I wait. And if my patient has been just taken randomly, I give 5 days of letrozole, and from 6th day, I start my gonadotropin.
Dr. Meenakshi, would you have some different opinion?
I think I'm quite okay with starting with letrozole. That's what I think all of us, because I'm not an IVF specialist. I'm a routine gynecologist who practices infertility. I'm very comfortable with letrozole. And probably if required, I would add gonadotropins at a little later time if I don't see response. So
1 or 2.
Okay, I mean, that's what I would use. I don't use Clomifene any longer.
You are doing absolutely correct thing. This was a theoretical situation where I just wanted to bring into notice that patient where threshold is not met, we can do it like this also. But for all the practical purposes, we are giving our oral ovulation first, and then when and where needed, we add gonadotropins.
One more thing
Here I want to add something.
One more, yeah, one more thing I want to
Seema,
add.
thank you for good feedback. We have got very intelligent, very knowledgeable panelists. Here I will like to share my experience. I do use letrozole plus CC, and I found a better result with that. In number of patients, I have found. Hello.
मैम आपकी आवाज कट रही है बीच में.
No, I think I'm.
Dr. Anupama,
My
I want to
card
add
is.
one more thing.
Apurva,
I wanted to add using
Yes,
using extended letrozole protocol in patients of PCOS who are not responding by 5-day dose really gives a good result, and up to 10 milligrams.
Yes.
So probably before going for gonadotropin, I have seen in these patients who are not responding with clomiphene or not responding with letrozole 5 days course, just giving them 5 milligram for 10 days really shows some result and some response, as what Dr. Seema was talking about. The FHS threshold somehow is reached in these patients, and thus they can be, even after that, you can give gonadotropin if they're not responding. The amount of injections which you use will be definitely lesser in those cases.
Dr. Anupama, I just have a point here. I mean, actually, it's more a question because, I'm not as wise as most of the IVF specialists here. Is there any literature which said that you can combine letrozole and clomiphene like was being mentioned just now? Because I've never done that or heard of it. So I was just wondering whether it's the right way to go.
बहुत recent सा evidence मैंने एक डाला है.
May I just add one more thing, Anu, for just audience's benefit?
Yes.
Yes, Seema, please.
Yeah, since we are talking about oral, wider use of oral ovulogents, so there are two protocols. I wasn't discussing extended protocol because we were talking about IUI. In IUI protocol, if you just want to stick on letrozole or oral ovulation and your 5 days dose is not working, you can go for extended protocol as this Dr. Ekika has said, but that is increasing the window only. We are making the window wider so that we get bifollicular selection. But if you are not able to meet your threshold, you can go for a step-up protocol of letrozole, where those 10 tablets, letrozole is a wonder drug, those 10 tablets you can use in different permutations and combination. And if you start giving 1, 2, 3, 4, that not only gives rise to multifollicular development, sometimes it works better than other protocols, even gonadotropin for CC non-responders or people who want multifollicular growth for IUI cycles. So you can do with that protocol also, you can use in your day-to-day IUI cycle.
There are a lot of pearls for our viewers, and let's hear Apurva's pearls too.
I think I completely agree with what Dr. Seema has just mentioned. The role when we are kind of looking at using oral ovulogents, or especially with respect to CC resistance, or considering doing a prolonged stimulation with letrozole, I think all of this is effective when we are trying a natural cycle for them, or when we are trying a timed intercourse for them. And, we are telling you that, okay, you take the tablets and, you can kind of try naturally. But when we are targeting an IUI section, I think there is no need to kind of really hold back from using gonadotropins.
I would think that
मैं पैनल डिस्कशन सुन रही हूँ. ठीक है, आप काउंट ले.
गीता, क्या आप चुप करेंगे? So at the end of it, I would want to say that there are so many ways of going about, and bottom line is this, that we want multiple folliculogenesis, not multi-folliculogenesis. We want 2 or 3 follicles. And for that, we would want to be little more aggressive than a very standard natural cycle. And for that, there are various ways, and depending on the patient, the stubbornness, the resistance which the patient has, according to that, we have to move forward. It is oral or gonadotrophins. Gonadotrophins, no doubt, would give us better results. But also there is a sad part to it that multiple pregnancy or OHSS risk is there. So Apurva, can you just compare CC over letrozole in brief?
I think I've stopped using clomiphene citrate for the past 6-7 years, ma'am. I've never used clomiphene at all. Letrozole, I think, is a great drug for PCOS, and 90% of the patients that we actually kind of do with respect to IUI, even though we are doing it for a male factor, they do have a certain PCO component which is there. Even for poor ovarian response patients, I feel clomiphene does have some amount of negative impact over the endometrial lining. Even for endometriosis patients, letrozole is going to kind of act, as we now very well know, the anti-inflammatory properties also, it is going to kind of act at the pelvic floor level. So letrozole, I think, is a very good drug which will kind of effectively act in all spectrums. Only in a situation wherein I think the patient has not responded to letrozole or is allergic to letrozole or something like that is where I would probably consider using a clomiphene citrate. I think as a dictum for all PCO patients, we should consider letrozole as first line drug.
Basically, it is the less duration of letrozole which is also doing the wonders, and the effect of letrozole would wash off faster. So the bad effect of anti-estrogen would wash off earlier, and that is why the results in the long term would not, the bad effects of CC which we see would not be there. And still looking at the literature, CC is still not outdated and it is being used. And at the point of time when letrozole was not in India, at that time where CC was not doing, tamoxifen was the drug which was used as a second line thing. So
here I would like to add one thing, that most of the time when patient coming to gynecologist, IVF specialist or infertility person, they have been already given too many times CC. So that is also one more point, because we are starting with letrozole.
So Apurva, can you just name a few conditions in which you will definitely go ahead and add gonadotrophins, despite knowing that the letrozole and CC and tamoxifen other options are there, but in these few patients you will definitely go ahead and add gonadotrophins?
I think you've already mentioned that, with respect to CC resistance, honestly, for all my IUI patients these days, we use gonadotrophins because they've become safer and, they are easily available. And we know that, multifollicular development is much more easier when you are adding, a combination of oral ovulagens and gonadotrophins. And, we can effectively control the risk of OHSS as well. The advantage of being able to titrate the doses, which was probably not available in the past. Now that we have multi-dose vials that are available, even for HMG, we can titrate the doses and make sure that we are getting the number of follicles as we anticipate. So my say would still be, use gonadotrophins for all patients that you're kind of considering, an IUI in order to increase your pregnancy rate. But as you've already mentioned, clomiphene resistance and, hypo patients, here, I think I would want to add that for hypo patients, we have to give both FSH and LH component. Giving only FSH component is not going to work out, and we have to start with a higher dose, and sometimes the dose can be as high as 150 or 200 units also. And here again, using oral ovulagens is not going to be effective. We have to start right from the second day with HMG preparations itself.
Perfect. Thank you so much, Apurva, for that. And I would finally conclude by saying,
can I add 2 more things?
Yes, Seema, please.
Yeah. Whenever we are talking about using gonadotrophins only, I would like to add hypothyroidism and hyperprolactinemia. These are the situations where oral oestrogens don't work even for plain ovulation induction. You have to rely on gonadotropins apart from hypo. So these are conditions where you have to use gonadotropin, that to HMG.
Perfect. So finally, I would say that gonadotropins are such a wonderful thing. All of us are endorsing, but probably the new thing has come up that level 1 clinics might not be able to use gonadotropins. So that is why I brought it up that although gonadotropins are the ones which will definitely improve the result, but all those who are doing IUIs have to have level 1 registrations, and then they should nidar hoke, they should start using gonadotropins. Meenakshi, maybe you can be the brand leader, right? Okay, so Seema, can you take this one?
Torch bearer, yes, ma'am. Meenakshi ma'am is always the torch bearer for it.
Yeah. So Seema, can you take this? Is there any role of agonist in IUI cycle, and is there any role of antagonist in what situation? Just briefly.
Yeah, very brief. So for all the practical reasons and purposes, there is no role of agonist in your IUI cycle. And only exception is some stage 3 and 4 endometriosis. So let's forget it. There's no role of long protocol as down regulation. I'm talking about GnRH agonist, right? Antagonist cycles, yes. If your patient is elderly, she has had history of previous premature LH surge, premature luteinization, her follicle is shorter. If she is a polycystic ovarian syndrome patient, she has shown the signs of early secretory changes. These are the candidates where there is multifollicular development. As Apurva was talking that gonadotropin, we have got that control now. So we are aiming at 2 to 3 follicles. So those are the candidates where by adding antagonists, as of now, 25 to 30% of IUI cycles, they suffer premature LH surge and luteinization. And to prevent that in all these situations, you should be using antagonists and they improve the results.
Perfect. Thank you so much, Seema.
I hope I was short.
Yes. I wanted you to bring this up that when the follicles tend to rupture early, these are also the patients in which antagonist is to be added. So you wonderfully brought that up. Thank you so much. Apurva, maybe you can take this. What is the role of adding estrogen in IUI cycle? If you're not happy with the endometrium, will you add the estrogen there? Meenakshi, maybe?
Dr. Ekika is also visible.
I can answer this. So I normally, if I'm not happy with the endometrium at a basic level, I do add estrogen. So, and I usually give an estrogen for about 10 days, starting from the time I decide to, when I see that the endometrium is not good. And I guess it works, so I think it's okay.
Maybe Ekika, would you want to add something?
With clomiphene cycle, if you go to see, I mean, the physiology, which will be actually Dr. Seema is better person to explain about all that. There is absolutely not much role of estrogen, adding of estrogen when we go to physiological way. So probably, I mean, in a IUI cycle with clomiphene, if I'm not seeing endometrium, I'll think of either it is because of clomiphene or maybe patient is having some kind of endometritis that it is not growing. In my personal practice, I don't add estrogen with the patients in CC cycles. And I think Seema Didi will be the right person to explain the physiology, why with clomiphene cycle estrogen, I mean, it's said not to be added.
Basically, the evidence says that estrogen levels would not be there if you are adding estrogen, not at the level of the endometrium. The pinopods which are there at the endometrial surface, which will help in implantation, they are not improved. So even if you are giving that extra estrogen, it is not actually going to help you. So
I think what
for this in practice, but yes, somebody was saying something.
Yeah, probably.
Yeah, I was
once
saying,
the
ki, ma'am, sorry.
Okay.
Apurva,
Yeah,
maybe
Apurva,
you
go
can.
ahead. Apurva, go ahead.
Apurva, bolo.
Yes. So I was just saying that I think one thing we need to understand is, especially when we are using oral ovulagens, if we start the estrogen too early, there is a good possibility that you will not develop a follicle itself.
That's true.
So even if there is any minimal role of adding estrogen, then it has to be in conjunction with using a gonadotropin. We simply cannot add, estrogen in a cycle with oral ovulagens before this thing is established.
And it is being well said, as said by Apurva, even 4 milligram to 6 milligram estrogen addition can lead to suppression and poor follicular growth. So probably not much role of estrogen as such. What I wanted to say when I said endometritis, sometimes, we start the cycle without even having an assess of one cycle without estrogen or anything. Sometimes these patients' endo is not growing because it is having some chronic endometritis, and we blame it on the clomiphene. Oh, it is because of clomiphene it is not going. So we really have to demarcate both the things and then decide what next we have to do.
Basically, if the lining is not there and there is some estrogen deficiency, probably your follicle is not producing enough estrogen.
Yeah.
So that follicle is defective, and you should have to look back at your stimulation protocol, and the next cycle would be something different. If you have given CC in this cycle or letrozole in this cycle, maybe you should be switching to gonadotrophins in your next cycle. This is what the lesson would be there from a thin endometrium rather than adding estrogen. This is a very common thing which we are doing. So that is why I wanted to bring it up. And even if the endometrium is thin, you can still go ahead with your procedure, because you can still get results. It is not that the typical 8 mm plus thing is required. Even with 6 mm, actually with letrozole and CC, some little smaller endometrium would also do. So next I would ask Dr. Ekika, Dr. Meenakshi, sorry. How would you trigger, and what are your thoughts on it?
So as a routine, I do give a trigger because I think it also helps me plan my IUI, because I have to be, dependent on the lab also. So it's always good to plan it out. So normally I would give the trigger, if it's just an oral medication trigger, probably at about 18 to 20. And if it's a gonadotropin one, so probably at 18, and plan the IUI about 24 to 40 hours later. And also, with this how and when, or do you want to know what also I'm going to use?
Yes. What also, everything about trigger.
Yeah. So I think literature says that 5,000, 7,500, 10,000 gives the same sort of result. I've been using 10,000 for a long time. I'm comfortable with it. I use it. If by chance the follicle doesn't rupture with it when I use it, then probably in the next cycle, I would try something like a recombinant HCG at a, 250 or whatever, this thing subcutaneously. And that usually works well. So that's a trigger I'm using as a routine. And I think, maybe.
Thank you, Meenakshi.
We already discussed when we are not going to trigger. I think that we've already discussed. Yes. So this is what I would use.
Meenu, madam, would you want to add something on the trigger front?
Yeah, that is absolutely, Meenakshi has told absolutely right. Most of the time it is advisable. We need a little amount of HCG. 5,000 is good enough, but we are practicing 10,000 national unit of HCG. But in case of the PCOS, I use this thing, decapeptyl depot, 0.2 milligram, 2 milligram I use, and I give it subcutaneously for my PCOS patient. And definitely we have to give proper luteal phase support in those patients. Otherwise, 10,000 HCG, and if we don't get the rupture of the follicle, next cycle we prefer the recombinant one. But in PCOS, I prefer giving decapeptyl depot.
Ekika, your comments?
Yeah, actually, besides, this is what we have it written with us, like if 16, 17 millimeter of follicle and we have using gonadotropin, we can trigger. And with clomiphene, when the size goes to 21, 22, it is written, and generally we follow this. But I would suggest, see, we are seeing only one or two dominant follicles. So it's good if we can do color Doppler and see the proper maturity of the follicle. 2/3 of the flow is there. And then if anybody who can do and see the values also of the RI, if it is less than 0.4. So this is the ideal time to trigger. Now, sometimes this is reached in most of the cases when the follicle is somewhere between 18 to 22. So in both the cases, not only, I mean, in clinical experience, I'm telling you, in both the cases, even if you're using gonadotropin or you're using Ovulogens. So probably besides the size, if we are good enough, then at least see the color flow of the follicle, see the maturity and all those Doppler.
And the endometrium as well.
Yes, and the endometrium as well. So probably once the color flow starts when the flow, the follicle reaches towards the maturity level, you will see the color in the endometrium also starts becoming better and better. And it becomes till the zone 2 or zone 3. When it is zone 3, it will definitely, if everything is fine, the follicle will be having 2/3 of the flow. So this is the ideal time to trigger. I mean, sometimes I've seen this when the follicle has reached 23 millimeter also. So I think flow, if somebody is good enough, that will optimize the cycle of IUI.
Basically, you can go ahead and wait even till 22, 23. But if gonadotropins are there, then
17, 18 probably, yeah. That is the time when
probably reach that maturity a little early. So
Yeah.
that is why the 17, 18 mm thing is set. Seema, would you want to add something else?
Yes, Anu, thank you. So first of all, I would like to answer trigger or not. There are two school of thoughts. Whatever that goes physiologically, that is better because there is a natural selection. As we are talking about the rupture, this trigger, what are you doing? You are doing surrogate. As a surrogate, you are doing LH surge. And this surge, when you are creating artificially, sometimes this follicle is not ready to give you a mature follicle. That dormancy of the oocyte is not taken care of, and it is not gone into the active meiotic phase. So trigger or not, you can do both, and evidences say that both are good in terms of pregnancy rate. The advantage of giving trigger that you can plan your IUI cycles. It is not coming like on weekends, you have to go somewhere. Those are the advantages. Disadvantages, you can give trigger on an immature follicle. For that, as Ekika told, that you have to rely on for different, now we are practically and knowing everything that gonadotropin require lesser size. If it is CC letrozole, you have to go beyond 20. If you have perifollicular blood flow study, you can do more than 2/3. You are doing, that's fine. So trigger or not, it is up to you. If your patient is very apt with LH surge or previous cycle, if you gave trigger and it wasn't working, then next cycle you can go for natural rupture and you can follow the IUI. But for all practical purposes and for all the newcomers, it is always advisable to go with trigger and then go for the IUI 36 to 40 hours later. Second thing, how much? It is 5,000 is more than sufficient. You never require 10,000. Even in my IVF practice, I've never used 10,000 international unit of SCG for bringing the trigger. Somewhere around 37 international, 100 international unit is sufficient for an average Indian women's weight. Third thing, I was talking about agonist trigger. For all practical purposes, agonist trigger is not meant to be given for IUI cycles, except for clomiphene, where there is follicular endometrial asynchrony. There are two papers describing that these are the patients who were benefited. if you want to give lesser amount of SCG, you can go for dual trigger. It will work similarly. It will bring out FSH surge along with surrogate LH surge as it does in your IVF cycle. So if you want to experiment, you want to really decrease the dose of SCG in fear of OHSS, please go for dual trigger. That is my favorite thing. If you are a novice, that is better than going for 5,000 or 10,000 international unit, especially if you are doing PCOS IUI.
Thank you, Seema. And I would finally thank you again for making me write a chapter on trigger. And that was the reason why I went so much into trigger things. And I should make one or two more comments on triggering. And one is that so the thing is that for triggering, one should understand that it is the dose, standard dose is 5,000 in Indian scenario, and it is only the BMI, very obese patient that would require a 10,000 dose. So standard dose would be 5,000 or 6,500 if you are giving a recombinant one. So go for 10,000 only when the patient is really obese, otherwise you really don't need it. And dual trigger, as Seema has told, there are situations in which you want extra FSH surge as well, where you would want to add that. There are 2-3 different things which one should keep in mind. One is in endometriosis patients, mild endometriosis in which you are planning an IUI, you should plan your trigger little early. Ultimately, khel sara LH versus trigger ka hai ki LH surge endogenous aa rahi hai. So if your patient is something who would come, who's happy to come daily and you are happy to cater to her daily, in those patients, even a endogenous LH surge would do the job. And as Seema said, that you can just follow her, and the day she ruptures, you can do the IUI. But if you want convenience for yourself, your staff and everything, then this is the way. So for beginners, it is the trigger, and what you have to learn, the art of triggering is that when to trigger. So the size thing is little nuances. So remember, when there are patients in which previous LUF has happened, maybe in the next cycle, add gonadotropins in those patients and trigger them early. So that is a better time to trigger those patients. Size should be lesser. As Ekika said, with gonadotropins, the size should be lesser. With CC, you can go up till 22, 23 size also. Dose, I think we have done. We are done with it. There is one more last. Yeah.
I just want to ask one question from Seema. She's telling about the dual trigger in PCOS patient. We can give agonist. Along with that, we can give SCG. You are advising how much dose you are giving? 1,500, 2,000, or how much you are giving along with?
Hi, Meenu. Nice seeing you.
Hello. Nice to see you, Seema.
Yeah. So 1,500 is very cumbersome. We are not getting it. So
Yeah,
I'm
right.
2,000 along with 1 ampule of Luprite.
Okay, Luprite.
At the same time,
simultaneously. Okay. Great.
And
Good.
urinary
So,
versus recombinant, everything is okay. You can give everything. I personally, recombinant is my favorite because I feel that it is a better quality. The prion peptides are not there. If you would understand what are prion peptides, then you...
Anu, sorry. I was somewhere else. I was talking about my dual trigger in IVF. For IUI cycles, I use 5,000 units because I am not scared of OHSS and multiple follicles. So there I give full dose of 5,000 even along with
IUI पे हमने agonist triggers पे ज़्यादा नहीं जाना है. It can be dual sometimes really, but agonist cycle में हमें चाहिए luteal support चाहिए. इसीलिए हमें HCG trigger चाहिए. So
my experience, Anupama, I am using in PCOS and I am getting very good results with using decapeptyl agonist as a trigger.
Great.
Anyway, it is an individual experience, and
that is why we are here. We are
go with the evidence also, but individual experience do matter.
Something else which I wanted, that something new which I learned yesterday was that in these days when we are giving letrozole extended protocol, in those patients, try to trigger them even when your sizes have come. Try to trigger them 2 days after, at least 2 days after stopping the letrozole, and not immediately after that.
Exactly. That is very correct.
चलो जी आगे बढ़ते हैं. Okay, अब एकिका बताएगी हमें कि would you document ovulation and then do your IUI? If you do not, then what do you do? Ekika, can you comment on all those things? Ekika is around? Okay. I think Meenu ma'am, can you take this up?
What is the question, Anupama? What is the question?
Ovulation patient को हमने trigger दे दिया, लेकिन उसका हमें rupture दिख नहीं रहा. We are not, we have not documented her rupture after trigger. What do we do now? Did we do the repeat?
We have
This
to
is very,
see.
very common questions from freshers that did we give a repeat trigger or not?
When we are not able to see the rupture, most of the time I do trigger, I give trigger and I do IUI between 36 to 40 hours. Even if the trigger is not there. Sometimes triggers occur after 48 hours, but the accumulation of the sperm in the uterine cavity is very important. So sometimes even the rupture has not occurred and you have done IUI, we get good results. But if we are not able to see any evidence of rupture, we can give double trigger. We can also go for double trigger while doing color Doppler and seeing what is the flow, and we can give double trigger also, and we can convert this cycle to IVF cycle.
Well, Seema, would you want to add something here? Maybe Apurva?
Is Apurva talking?
Yeah, ma'am. So I think so for us, I think it's a standard that we call the patient back 36 hours from when the trigger is given to kind of see for the ovulation. We always try and document based on if let us say I think all of us know if the egg releases, there is no problem, you are going to go ahead and do the IUI. But if the ovulation doesn't happen, the question is, will we go ahead and do the IUI? It is possible that, the window is 36 to 48 hours. So it's possible, the patient might just come down or step down from the ultrasound machine and, she will just ovulate sitting in the chamber itself. So as a protocol at 36 to 40 hours, we always do one dose of IUI. I think the probability of patients not rupturing at all, even after getting a full dose, is very less. In case if something like that has happened, then it means that we have actually misjudged the maturity of the follicle. We've probably kind of given the trigger a little too early, and the thickness of the follicular wall was too hard for the egg to kind of rupture. So for in these patients, subsequently, obviously, we should consider try and doing a delayed, trigger. But otherwise, I am never in the habit of giving a repeat trigger, so I really can't comment on it. I don't know if
there is no role of repeat trigger, because once given a trigger, the LH rise has occurred, the meiotic division has already started. Whatever is going inside the follicle, the oocyte, everything has happened. And if that has happened happily or not so happily, but there is no point of giving another LH surge, nothing more is going to be achieved. So there is no role of giving a repeat trigger in any of those patients. And if at all your rupture has not occurred, try doing an insemination the next day again in this patient.
Absolutely right. I agree with you, Anupama and Dr. Apurva. But sometimes there is LSS do not occur. And sometimes we have seen, even when we are doing IVF, we have seen that the follicle, we are finding empty follicular syndrome. We do not find any follicles.
And might not be correct.
The second trigger, we pick up, when we do the ovum pickup, we find the oocytes are there. So follicles are there, oocytes are there. The same phenomena can occur in IUI too. So sometimes if the patient is persistent,
the whole chain of your injections is not good, maybe then
because of the capability of the HCG, right?
One of your patients, Apurva, comes over and you have told her that rupture was not documented, you still went ahead, did her IUI, and the patient became, you did not do her IUI, you just told her to have a normal coitus, and she comes back pregnant to you. कह रही है मैडम आपने क्या किया?
हुआ है मैम, सबके जिंदगी में ये तो हुआ ही है. I think जितने भी लोग काम किए हैं सबकी जिंदगी में ये हुआ है.
How do you explain it to the patient?
को बता देते हैं कि that भी उससे. So with respect to the physiology of a human body, and more importantly a woman's body, it is always evolving, and it is never the same, and there are so many still mysteries that are there. But I think practically, in case if we kind of look at this, the egg is microscopic, so all it needs is a small vent for the follicle to kind of rupture. Even if the balloon has completely not burst out, a small egg has released, and it remains as a corpus luteum.
And it has sealed up again. Perfect, Apurva. So that's the answer.
Sure.
And this is a very common question of which I keep getting from gynecologist friends, that rupture hua hi nahi, and what to do now. So maybe the rupture still might have happened. Sometimes even echoes are not there in the follicle. Rupture has happened, and the progesterone rise will be the thing which will tell you that the rupture has happened. So how will you time, Apurva, your IUIs? You have triggered your patient, and now at what time? A paper says 0 to 36 hours, another paper says 24 and 48 hours, somebody says 34 to 36 hours. So what was your take, ma'am? Apurva.
Ma'am, see, the whole concept regarding this is that, okay, once the egg release has happened, the follicle has, the egg has to kind of enter into the fallopian tube. And if you are already instilling the sperms into the uterine cavity, they also have to travel through the fallopian tube and reach. So based on this, I think logically, we need to kind of keep it that 36 hours is a good time for us to kind of go ahead and do the IUI. I don't think doing it 24 hours. The only point wherein we can consider doing it 24 hours is if we have triggered late, if an ovulation has already happened, there was a spontaneous LH surge which has happened, and the patient ovulated spontaneously 24 hours from when we have given the HCG. That is the only time we can consider doing it 24 hours. But I think on a routine basis and as a standard, we should keep 32 to 36 hours. And ऐसा बार हुआ भी है, जहाँ पे हमें लगा कि that follicle थोड़ा और बड़ा है, and we tell the patient that okay, tomorrow, in case if you feel that there is severe pain or discomfort or something like that, please do drop in. It's possible that we might repeat an IUI, but standard I think is 30 to 36 hours.
This is what I wanted to hear from Apurva, that you should call your patients the next day too, because there would be, say, around 10% of the patients who would probably rupture early, and you should not miss your IUIs in those patients, because you want to do it around at the time of rupture.
Yeah, one thing I want to ask everyone, it's everyone, I want to ask their opinion. Do you allow them time intercourse, before an IUI? If it is not a very severe kind of male infertility, not obviously 10 to 20.
So I want to know evidence for this, and they say that the day of trigger do advise patients for intercourse, and then take the sample on the IUI day. In between, a day's gap would be there. And post IUI, same day, it is a good idea to ask the patients for intercourse. So that is the
So probably I just wanted that everyone should have this message that once you're doing IUI, that doesn't mean that there should be a total abstinence right from the day of trigger till the day of IUI. One should, it's alternate day, yes, on the day of trigger, and then wait for a day and give a sample on the day of the IUI.
I had a question related to this.
The basic reason for this, the number of sperms reaching the tube will increase. That's the only scenario, and since they last for 3 days, so probably it's a good reason for telling them to have a natural intercourse also.
The other reason for this is, Ekika, that, you don't want only the sperms to reach there. You want good motility sperms. So the fresher sperms are the good motility sperms. So it is a good idea to tell them to have intercourse. Unless until there is a male factor, and the semen quantity is less, in those patients, maybe the 2 days abstinence is the standard. But otherwise, you should ask the patients to have coitus on the day of trigger. Yeah. Seema, I wanted your inputs on single versus double IUI.
So I know if you ask my favorite personal opinion, I am a big proponent of double IUI. But if I'm speaking from public forum for public's benefit, audience benefit, so single IUI has equal pregnancy rate as compared to double IUI. And there are hardly very few indications where double IUI has to be used. And the most important indication is mild male factor. Or male factor, I mean, fine. In unexplained infertility, double IUI doesn't work better. There is a huge evidence. So recently, since this donors insemination has become so tough, getting sample and everything. So I'm sticking to single IUI. So for all practical purposes, you should be trying single IUI. If by some reason there are theoretical conditions, 2 cohort or something, or people were talking that follicle has not ruptured, you can go for double IUI.
Perfect. So basically it is, as Seema says, it is only the male factor, or sometimes when you have not documented your ovulation at the time of IUI, that is the time when you will do
And
it.
second thing I would like to add here only, that documenting ovulation is not needed at all. That's our practice. We have our ultrasound machine, so we are fond of doing that, but it is not. And that is how this question comes, that you said rupture was not there and patient conceived.
Perfect. Meenakshi, so finally we have decided that we are going ahead and doing an IUI. So what is the principle for this IUI? Semen preparation, what is the principle? Before IUI, you are taking the husband's sample and then preparing it. Why would you want to prepare it? Meenakshi, is it there?
Meenakshi is not there.
Okay, so anybody else can take it? Ekika? Ekika is around?
Yeah, I mean, you mean why we need to prepare the sample? Yeah,
Yes.
we need to prepare the sample because we want to get a clear, fresh sample which doesn't have any impurities and less ROS and rest of the things being taken care of. And a good motile sperm count is there. Post-wash sample. So it is obviously a yes for us.
Plasma, which we want to be segregated from the sperm, because seminal plasma is the substance which would not let the sperm be capacitated. It decapacitates it. So that is the reason. And along with that, we want to remove all the kachra, because that would let the uterus expel all the contents. So that is why we want to wash it. So you are able to collect the sample at your center, Ekika, and all other centers can do it. Your neighborhood gynecologist would be able to do this now?
No, probably I don't think so. With the new ART Act, you have to have a registration at the ART clinic number 1, clinic 1, if you are really doing just simple IUI. And even the preparation also cannot be done at any other place than a recognized center.
Thank you. Thank you for bringing it up. And even the pathology centers
will not be able to do it. Yes.
They will also not be able to do it. And it is the level 1 or level 2 centers that can prepare the semen sample.
So basically, with the new ART rule, any gamete handling cannot be done other than ART center 1. This message should be gone very clearly. I think that is very, very important.
Braj, maybe you can elaborate what all centers and what all requirements are there. If you can elaborate, Braj.
So yes, for doing any IUI ovulation induction, one need to get registered as ART center 1, and for that the requirement that it should be gynecologist, a full-time gynecologist should be there. There should be semen preparation things like all the machines and everything should be there, and it should be
only 3 gadgets are required as per the latest gadget. I just checked it up yesterday. Only 3 things are there in the level 1. So it is very easy. Just a centrifuge, a microscope, and a refrigerator. That's it. So
Yes.
everyone can apply. All gynecologists can apply for a level 1 clinic.
And it should be used in that center only. It should not be given to other place. That is very, very important.
And
So there are different forms, consent forms. That is very important. You have to keep documentation for IUI with husband sperm. The consent for can you come back? Yeah, consent form to be signed by the couple of women, and the form 6 is required. And this is according to rule
7 or 8.
13.
6 is for IVF. 6, 7, and 8. 7 and 8.
7 and 8 for IUI's husband semen, 8 for donor semen, and rest for the IVF centers.
बाकी सब IVF के लिए हैं. ठीक है. ठीक है. Thank you. Thank you, Braj. So, Ekika, we'll continue. Any importance of the timing from the collection of the semen sample to reaching your lab till you finish off with the procedure? Would you give any timeline to it which you would prefer?
Yeah, probably the collection and the reaching to the center should be less than 30 minutes. I mean, basically, it should be done at the very same place. The collection should be done hand in hand. The moment the patient gives the sample, we should start processing. But if like still there is some delay, and in some places, I don't know how much now things will be done in this scenario when everything has come up. 30 minutes time still can be taken from the ejaculation till the reaching of the collection place, and then the procedure immediately it starts, the liquefaction and the rest of the things as it proceeds. How long abstinence is required? 2 days abstinence minimum. I mean, again, this is a question which I would not. I mean, we have already discussed this. There is nothing for less.
This is the same thing which you had just brought it up. Yeah. So, or we should try finish the procedure. The standard which is recommended is 90 to 120 minutes. That is the timeline when we should try to finish it up. And say supposing the husband is not able to give you the sample, despite providing him a room or sending him with his wife, everything, but still he is not able to give the sample. What comes in your mind? And he is insisting that home sampling should be allowed. What would you do?
Probably home sampling is a big no. It cannot be allowed. It should not be allowed because there are a lot of legal aspects to it. And then I would not allow. I mean, I cannot tell you anything else. It should not be allowed.
Even if home sampling, the standard thing is that you do not allow, but sometimes you have to just let it go. And in that situation, you have to make it written, because sometimes, there is a AZU husband who would bring someone else's sample. So
Yes.
you have to get it in written.
That it is my sample and all the rest of the things. I don't know. I mean, it has to be written in their colloquial language and then their own words and everything, because we absolutely don't have any other kind of a form for this. But yes, one should maintain a diary. And this should be done even for the
patient के उसमें ही लग जाना चाहिए जहाँ पे भी उसके standard consent.
और जब आप collect, even if you are given the patient a can to get the sample collected even at your center also, so there should be a diary maintained in which it should be written and the patient should sign that it is my sample, and then it should be sent to the lab for processing. So these all things had to be taken care of very strictly, I would say, very stringently and strictly.
Meenu madam, would you want to add something?
Yeah, that is a real question. Many times it happens that the semen is not coming out. Sometimes we give the Viagra and then we ask to give the sample after 15 minutes. And if even this Viagra is not working, then patient says, I will go home and I'll. So then sometimes but you have to maintain and you have to write in the register, and you are absolutely fine. Right, Dr. Anupama. Sometimes they ask their friends to give the sample and they bring another sample. These things do happen. But when we are not able to, that is a thing. Sometimes you ask the...
One precaution is that you should be knowing about the AZU status before knowing about the status. So it is a good idea that you have done an analysis earlier before doing an IUI.
But it is, evidence also says that we can allow, if they are not able to collect sample, we can allow to go home and get the sample.
Some word about retrograde ejaculation, ma'am. How would you tackle that? Ekika?
I mean, though I haven't seriously done, but yes, it is
Oh.
that these people are told to give the urine sample, and from them the sperms, if it can be seen microscopically, can be processed. And
Yeah.
one reason of this inability to give sample can be a retrograde ejaculation. So for them, it is being told to give their urine, and then it can be seen, and if the sperm can be extracted from that. Though I haven't done this, but this can be done.
Well, we have done it quite a number of times, and let me explain it in short. That when you know this happens, usually it is a diabetic husband, and when you know that this is happening, then beforehand, at least 3 to 4 days before, you should give alkalizer to the husband.
Okay.
And before giving the sample, he should pass urine, and then he should ejaculate, and then put a catheter and take that sample, which is a urine sample through the catheter, because that is a better sample, because he's not able to give enough urine when he is just freshly passed. But your catheter and flushing with the media, that catheter sample gives you the best result. I think we've just done it 3-4 days back, and it gives wonderful results.
So it means penile catheterization, just like we do
K90, simple K90,
Okay.
and flush it with the culture media, the wash media.
Lovely, ma'am. Ma'am, I'm sorry to interrupt, but I guess we need to conclude.
Okay. So I'll just finish it off fast.
We
Apurva,
can just take some procedure of IUI in very brief by someone, how to do and what precautions in case of difficult scenarios.
Right.
Just by Meenakshi or Apurva, anyone can take this, and we can then conclude, because we are running short of time.
Perfect. Meenakshi, maybe you can take.
We can skip this preparation methods.
Yeah, preparation method में तो कुछ फर्क नहीं है. Well, the bottom line is this, that there is no difference. Go about with gradient, swim up, anything. When the sperm count is good, swim up is fair enough. It is only when the count is less that gradient method, or when their motility or morphology issues are there, then the gradient method is better. And in future, artificial intelligence probably will take over. And
trust me, I'm very, very dreaded with this artificial intelligence wala thing. This is really going to put talas on many of our work.
No, don't worry, Ekika, ये कभी नहीं होने वाला है. डॉक्टर आदमी को बिल्कुल डरने की जरूरत नहीं है. तुम्हारे बगैर किसी की
IT वाले तो बहुत डरे हुए हैं भाई. जब
IT वाले डरे ना, हमें डरने की कोई जरूरत नहीं है.
चैट जीपीटी आ गया, सब बिल्कुल माथा पकड़ के बैठे हुए हैं.
मैंने सुना है कि चैट जीपीटी जो है नीट के क्वेश्चंस नहीं सॉल्व कर पा रहा है.
Seriously?
Anu, can I leave?
Yes, you can leave. And Ekika, just
thank you,
closing,
darlings. Thank you so much. Bye-bye.
And मेरी एक request है.
Thank you, Seema, for joining today. Same with Apurva and Meenu.
Hi, Kavita. मुझे पता
Thank you, ma'am.
Thank you so much for joining today.
Actually, ma'am, I'm running fever.
Before Seema you leave, मुझे एक बात कहनी है. Before Seema you leave and anybody else leaves, मेरी एक गुजारिश है कि इस बार डॉक्टर कविता और डॉक्टर ब्रिजबाला, ये दो लोग यहाँ पर वोटिंग जरूर करनी है. हमारी ब्रिज इनफर्टिलिटी कमेटी के लिए खड़ी हो रही है, और कविता मैम तो सबको पता ही है, बिग बॉस है, तो प्रेसिडेंट बनेगी.
और मैं तो वही करूंगी जो अनु कहेगी.
Yeah, thank you so much for joining today. Really, I am blessed. सबके सब आ गए तुम लोग एक आवाज पे. Though I have not called you individually.
मुझे याद ही नहीं था ब्रिज को मैंने ये बोला था कि इंडिया
में. I didn't call you Appu and you and Ekika or Meenu.
तूने मेरे को बस एक बार
Anupama. But that's good that you all joined, because other things are there. I think Archana was here and Dr. Bakshi has taken.
Thank you, ma'am. Thank you so much.
Recording बंद कर दो भाई. Thank you so much. Thank you so much for joining.
Okay,
I think are we done, or we some more questions are there, Braj? And Anu?
We'll take one or two questions.
I think we have to stop now because we are running short of time. So,
okay, so then I'm concluding it.
Yeah, please conclude, and then we'll put a vote of thanks. Yeah, please.
Post IUI, the instructions are there that patients should be taking 10 to 15 minutes bed rest. That is what is advisable. Some people say that deep breathing would encourage a negative pressure inside, and that would help the travel of the sperm inside in the fallopian tubes. No role of antibiotics. All daily grind is allowed. Patient can work and have every routine chores, and the couple should have intercourse also. You should rather encourage, if possible. And luteal support, it is for natural cycle, it is not required. For gonadotrophin cycles, the standard of care says that you should give luteal support. All luteal supports, oral, vaginal, injectable, everything is good and has equal results. And vaginal gel also, everything is same. Congenital anomaly chances are increased or not. This mild difference is there versus natural cycle. It is just as in IVF, slight amount of exaggerated congenital anomalies are there. Similarly, it is there in this also. And when would you call it a day? The standard now says that earlier it was 6 cycles. Now they have come down to 4. And the very recent thing which we have just searched, I think 2-3 years back, this evidence has come up that 3 cycles are enough. And if we are not getting good result, if it is not for the donor cycle, but if the sperm count has been more than 10 and 3 good cycle attempt you have taken, then you should move ahead and go for this IVF cycle. And this was the trial in 2010, fast trial. That's it. And from the University of Sujalam Suklam Shasya Shamalam, thank you so much.
I think it was a wonderful panel, and it's always we never get we always get something new when there's a panel on IUI. So thank you so much for all of you for joining in for panel today, and it was a wonderful panel. Just one thing I want to say, when you were talking about that sample, if it is not being produced at the center and it's brought from the home, I think everybody was saying that you take in writing that it is my sample. What we do, that you have to basically do one more thing in the documentation, because patient can say, okay, it was my sample, I wrote it in. Keep a copy of it with you, not only leave it in the patient's file, that yes, it was the sample, and with a photograph and ID proof that this was the sample provided. Because patient's file, if you put, they may bring it or they may not bring it another
record
time.
which you are keeping. I mean to say the consent which you are keeping with yourself.
Yes,
IUI consent
yes.
we all keep. So along with that IUI consent.
That's the best point I wanted to just highlight again. So thank you, and it was wonderful to have all of you here on 3B platform. We connect again at this platform or maybe some other platform. So bye. Thank you, Braj. Thank you, Anu.
Thank you, ma'am.
And
Thank you so
thank
much,
you, everyone. Thank you. Thank you so
Bye,
much.
ma'am.
Thank you all my panelists.
Thank you, Dr.
Thank you,
Brijwala. Thank you, Dr. Anupama. Thank you, everyone.
Thank you, Minuji, for joining. Although you were traveling, but you could give your expert comment. That was excellent. And thank you, Anu, for moderating such a wonderful panel.
Thank you.
And Kavita Bapat madam, Maser madam, Bakshi madam, and thanks everyone, all the expert panelists. So we'll be
Thank you, MQ, for providing the platform, and thank you, Dimpy, for beautifully connecting with everybody and bringing all the experts on this platform. Thanks a lot.
Thank you, Prajwala.
Thank you, madam.
Thank you, Basir ma'am. Thank you, Pankaj ji, for the entire seamless program functioning. Thank you so much, Ensure.
Thank you, Appu, for joining. Thank you,
ma'am.
Anu.
Thank you so much.
Thank you, Anu, so much.
Thanks a
So
lot
nice.
to all
Bye.
doctors.
Mast maja aaya. Thank you so much, everyone. Thank you so much. Thank you, Dimpy Rani or Anupama.
Thank you, ma'am. Bye, ma'am.
Bye.
Apurva, lovely connecting with you.